Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast studio in Fall River, Massachusetts. Today, we're very fortunate to have Dr. Jerald Katz, Jim Hermenegildo, and Alvin Marcovici with us. And we're going to be discussing robotic surgery, and I know this is a topic that a lot of patients are really interested in. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are always greatly appreciated. Well, before we get going, I guess we should probably just introduce it, maybe just hear a little bit about all of you. Alvin's been on the show, Jim, you have, but Jerry, you haven't. So, Dr. Katz, why don't you start? Introduce you, just basically talk a little bit about your background,
okay,
and what you do.
All right, so my name is Jerald Katz, and I've been practicing orthopedics in this community for 35 years, beginning at both hospitals. Now I'm exclusively at St. Anne's, and I work for St. Anne's. And I have varied interests. I came to the community with a pediatric orthopedic fellowship, and it's kind of mushroomed into more adult medicine. I do a lot of joint surgery now, and I use a makoplasty robot, which helps me do the surgery, which we'll get into later. I enjoy the area. I enjoy all aspects of surgery. And that's pretty much about it.
Yeah, that's great. Excellent. We're glad to have you here. Thank you so much.
Yeah,
I'm excited to have the three of you to talk about this topic, because you're all going to approach it from a different perspective, probably to some extent. And Dr. Hermenegildo.
I'm James Hermenegildo. I've been here since 2002. I use the Da Vinci robot to do intra-abdominal procedures. Probably have done about 3,000 to this point, involving gallbladders, hernias, and colons. Great outcomes. I'm part of Brown Healthcare, primarily out of St. Anne's Hospital.
Great. And last but not least, of course, a return guest, Dr. Marcovici.
Chris, Nancy, thanks for having me back.
You're welcome.
It's always a pleasure to have I'm looking forward to our discussion. For those who haven't seen the prior introductions on the other podcasts, I'm a practicing neurosurgeon. I've also been here since 2002. This is the only region I've ever practiced. I operate at St. Anne's Hospital with my friends, and I also perform a lot of robotic spine surgery, and also use its cranial applications as well.
That's great. So we have a general surgeon, orthopedic surgeon, and a neurosurgeon. You've all probably used the robot, and obviously in different ways, so we're going to learn a lot about that. But do you want to start, Nancy, with your first question?
Just when you were just talking, you said something interesting. You used the robot. So it's the robot? You all don't have your own
No, it's many robots. 3 robots.
Okay. All right. So for different specialties, you have a different robot. That was cool.
Actually, the Da Vinci robot covers multiple specialties. You can use it for thoracic, GYN, urology, general, hepatobiliary, and urology.
Does the robot, can you just like broad stroke the robot for a minute and just, is there any programming that's done in the robot? Like, how do you create one of these?
The Da Vinci robot has 4 arms.
Okay.
And where we sit is approximately 6-7 feet from the robot, from the patient, the table. Every move that we do on the robot, it moves inside the patient.
Okay.
It does not move at all without us touching.
Okay.
If our head comes out, it freezes everything.
So those are the safeguards.
So you're looking in a screen.
You're looking at a screen. It's 3D. It's magnification. And the pros of the robot, the Da Vinci robot, is you have high power magnification. You have arm stability. There's no shaking. Each arm has wrists. So when you do straight laparoscopic, you only can go up, down, in, and out. You can't go around corners. You cannot operate on the abdominal wall. With the robot, you can go 540 degrees at the wrist. You can get behind things, on top. And that leads to the benefits of robotic surgery in the abdomen. Decreased conversion to open surgery.
Yeah.
Decreased hospital stays.
Yes.
You can do more difficult cases. Instead of going right to open, you can actually complete them robotically. Decreased blood loss. And article after article has shown that all the metrics that we judge surgery by, there's an improvement on robotic surgery from laparoscopic in every one of those metrics.
So then when you're talking about conversion for open surgery, so you're not getting an incision, so that's also decreasing on the pain and everything else.
It's been clearly shown that patients that have robotic surgery even take less pain medication than laparoscopic surgery.
And then their bills are cheaper. They're not in the hospital for...
Well, I don't know. Is that true?
People always question, how about the cost of robotic surgery? The payment is the same. So minimally invasive surgery, whether it's laparoscopic or robotic, is still minimally invasive surgery. So it's not that the cost is higher. It's the same or cheaper. In fact, once you get down and hone down the number of instruments you need for a case, it's actually cheaper than the comparable laparoscopic case for gallbladder, for colon, for hernias.
Cheaper for the hospital or for the patient, or?
It's cheaper for the whole system.
Yep.
And for the patient, you get the benefits of going home the same day, not having an open operation. And we all know that open operations lead to seromas and hernias and all those other complications. You don't have that with robotic surgery.
Okay.
So when you were talking about all the manipulation, like, it can do this and this and go upside down and everything, does that mean there's more manipulation inside the body?
When the body's inflated with CO2, so you have about 15 millimeters of mercury of CO2. So the port that's in the abdominal wall never moves. It's the instrument inside that moves. So there's no more stress on the abdominal wall. It's free in the abdomen, and then the instrument just rotates wherever you need it to go.
So that's just a huge benefit without any
How many holes do you have to make in the abdomen to do, let's say, a typical gallbladder surgery?
So a hernia is 3.
Okay.
Gallbladder is 4. A colon is 5.
But they're small incisions compared to complete open abdominal incision.
Definitely. Even the, for example, for colon surgery, even if you do a hand-assisted approach, you still have a 7-8 centimeter incision to do your hand, whereas when you complete it robotically, you have a fan and steel incision that may be about 3 centimeters tucked down where a C-section.
So it's just a little inch and a half or so.
Yeah.
Or an inch and a half. That's great.
So then when you're using the robot, does it feel a lot different than when you're actually, like if you're not using a robot?
Everything's a learning curve. So you start off, and I was trained in the 90s, so open, and just when they were going to laparoscopic.
Right.
So back then we had a lot of surgeons that they did some laparoscopic and they go, oh, it's too hard, I got to open.
Right.
So I saw open, and then we saw laparoscopic, and it's just a transition. So now you're feeling tissue. Then laparoscopically, you're still feeling it, you're pulling on it. Now you go to the robot where you're not really feeling it. You have to use other cues on what you're doing, how hard you're grabbing, how hard you're pulling. You've just learned other cues on how to operate.
So you talked about a safeguard, like if you're not in there, it kind of just freezes. Yep. So if, not specific to you, but if you make a wrong turn, is the robot like, hey, this isn't what we were planning here,
If you are in control of the robot will move when you move.
Okay.
So how you would do an open laparoscopic or robotic surgery, it's you do what you...
So basically you've turned into a bionic man when you're doing this. It's still
Okay. And the other great thing about robotic surgery is there are other added benefits to help you do your surgery. For example, we can inject a dye for gallbladder surgery, and the common bile duct lights up green through the robot. So now I can see where the common bile duct is, and if it's a particularly hard case and the bile duct is really inflamed up to the gallbladder, you do not get a common bile duct injury, which has been shown in the literature. With colon surgery, you can light up the ureters, and you can see those robotically. and you don't get an injury of the ureter. When you do your connections of your bowel, you can actually inject a dye that shows that you have good perfusion to the ends. So when you do your anastomosis, you know that it won't get ischemic. None of that stuff
Meaning,
is...
I'm just translating for the for the audience, just meaning that there's good blood flow.
Yeah.
You can tell.
So when you do your connection, you want to make sure there's really good blood flow to the ends when you connect.
Right.
If there isn't good blood flow, you can have complications from your colon surgery.
Does that have anything to do with like the amount of scar tissue? Does it decrease on scar tissue, or does that have nothing to do with
Post-operatively, so if you do an open operation, patients will form a lot of adhesions in their abdomen, which will lead to bowel obstructions at a later date. Okay. When you do a laparoscopic or a robotic procedure, there's almost no scar tissue in the abdomen.
So is this, and this is a question for everyone, is this the standard of care now that you learn, everyone's learning robotic surgery? Or is this?
The answer is, yeah, it's basically, as Dr. Hermenegildo said, this has been a progression. You know, in Jim's field, it's from open to laparoscopic to robotic. And in orthopedics as well. I mean, we still have open incisions. I'll get to the macoplasty in a few minutes, but it's now the advantages of robotic surgery have been well known now and written about, and so training programs are now teaching, residents how to do this. So this is basically the way of the future.
Is it replacing hands-on surgery? Is that?
I don't think so. I think the three of us will tell you that surgeons need to be surgeons, because there are times that you have to open, you have to do what you have to do, and in the case of orthopedics and knee and hip surgery, we're still making the same approaches. It just makes us do it more accurately. So I don't think this diminishes surgical skills. I think it enhances our skills and makes us do a better job.
So I was going to just ask, so, we heard Jim talk about his experience as a general surgeon, but as an orthopedist, how do you use the robot?
Okay.
It must be used differently, I'm guessing.
Well, it's a little bit different than in Jim's case, where we still have to do the surgery to get down into the hip or get into the knee. So it's still going to be the same approach, very similar approach. The advantage of this macoplasty robot, and I'll explain how it works in a minute, is that it helps us do the job, do the cuts that we need to do to put the implants in a better position, so that there's reproducibility to it. So that, for instance, if you're putting a hip socket in a hip, you know the precise angle that you're putting it in 3 dimensions, okay? And it's reproducible every time. And the reason why it's important is that you have a lower risk of having the hip pop out or dislocate afterwards if you're putting the hip in the right position. In the case of a knee, if you are checking ligament balancing and doing what you're supposed to do with the robot, it means at the end of the day, the knee is much more stable. And what's much more stable, it hurts much less, okay? So that the post-operatively there's less pain as well.
Is there a difference with infection rate or any of that? I would think it'd be similar maybe, because you're still in there, doing your thing.
Well, I will tell you that from orthopedics, I don't think there's a difference, because you're still making the same incisions.
Right, that's what I would think.
Maybe robotically in the abdomen it might be.
The abdomen, it makes sense.
So the infection rate generally is around 1%.
And the healing time is...
healing time is about the same, which is basically in orthopedics, it's just helping you do the job better.
So you can get the alignment right and all of...
Right. Reproducibly, every time it's perfect.
Nice.
And every x-ray you take afterwards, the implant's the perfect size in the right position. It's the reproducibility of this that makes it so appealing to me.
Okay.
You can't do a bad job. And as far as the robot and doing something wrong, the robot doesn't let you. It has pretty much goalposts. Let's say I'm using the robot to do the cutting, So let me just go into it a little bit, just to make this make a little more sense. Preoperatively, let's say in a knee, we'll do a CAT scan so that the robot has an idea of what the knee looks like in space. At the time of surgery, we put these reflectors through pins on the femur
like
and
markers,
the tibia.
yeah.
They're markers. So those are the eyes to the robot. And then we use another reflector and touch different areas of the knee. So now the robot has a 3-dimensional area in space of where the knee is. Exactly. And you can compare it to the CAT scan.
So then it becomes very specific to that patient.
To that patient, exactly. It was exactly. And so when you were planning the balancing and how you're going to put these implants in, virtually you can position them in infinitely different positions, whereas before the robot, everybody had these mechanical jigs. It was like carpentry. You would put a rod up the femur, you would attach a jig to it. Everybody got cut the same way in terms of the cuts for the knee replacement, which was good for most people, but not everybody. And that's where you had ligament injury, ligament instabilities. So that doesn't happen with the Mako because you factor that all in, and you virtually position the implants before you make the cuts. When you bring the robot in, the robot knows because of the CAT scan and what you've done in terms of touching the knee, where the back of the knee is. So the saw will stop at the end or the back of the knee. It won't go beyond that, so you won't have any kind of nerve or blood vessel injuries. It'll knows where the boundaries of the knee are on the inside and the outside, or medial and laterally, we like to say. So it prevents you from, or it keeps you from causing any type of ligament injury on the side of the knee. So it's a lot safer in that way.
So you get optimal placement.
Exactly.
Like, does the robot, does it signal you when you reach that optimal placement? Like when you
as you're doing the...
Yeah, like, on Top Gun, like when you lock in, there's like a green screen.
Well, unlike what Jim said, in the case of my robot, it doesn't let you do anything wrong.
Okay.
That when you get to the end, the blade stops.
Okay.
Right? If you tried to make the wrong cut, you couldn't. It wouldn't start. It wouldn't do it. It would do it according to the plan. So it's very safe in that way.
So what are the similarities and the differences with what the other doctors talked about to what you're doing?
So in neurosurgery, robotics and neurosurgery is sort of a latecomer. When you talk about standard of care, that implies that most, or if not all, neurosurgeons and spine surgeons should be using the robot, which is not the case. In fact, we have the only robot in the area. So we're sort of unique in that respect. So we're sort of on the cutting edge of this. Robotics and neurosurgery is certainly the most recent in comparison to orthopedics or general surgery and the other specialties that use those other robots. And our robot is very similar to the robot that Jerry uses. It makes everything perfect. And I think a lot of people listening to this podcast, have watched a lot of science fiction and seen Terminator, and they think the
robot's
iRobot, yeah.
So the first thing I think I just have to clarify is that we are doing the surgery. The robot does not do the surgery.
Okay.
We do the surgery. We do the planning. We do the cutting. What the robot does is makes us better surgeons. It makes it perfect so that, after surgery, when you do x-rays and things, it's perfect. It's textbook every time. And it really just minimizes that margin for error. It's actually funny that you talk about the little Top Gun locked in.
Yeah.
My robot does allow for some freedom and movement. And when you're exactly down the path, it actually does give you a green box saying that you're
Locked in, good to go.
You're good to go. So keep going where you're going. You're on track. For the most part, the robot that I use is very, very similar to the one that Jerry does. We use it in the spine for placement of screws and cages, and it makes sure that it's perfect every time. And similarly, it's tailored for the patient. So the patient gets a CAT scan, and then, people come in all sorts of different shapes and sizes. We tailor the perfect screw and the perfect cage for that patient. And 99% of the time, it comes out exactly like that. And what's really exciting is its uses for brain surgery as well. I am old enough to remember first coming out of practice before there was what we call image guidance. Yeah. Image guidance is sort of using a MRI in the operating room.
Yeah.
And before that, it was just really taking a best guess. Mm-hmm. And it many times could be like horrific because you open up the brain and you say, okay, we're going to go to this brain tumor. And quite often a small brain tumor was more frightening than a big one because a big one is easy to find. A small one can be treacherous. If you're looking for a pea inside someone's brain, you can imagine how difficult that is. And first we just used to guesstimate. Then when you missed, it was just horrific because then you say, okay, which way do we go? Left, right, up, down.
Yeah.
And
scary.
So then image guidance came and it improved that so that the margin of error was much smaller. And now with robotics, it's 100% every time, error-free. And it really just makes it incredibly safer for the patients.
So you were very nice enough to supply us with a kind of an educational video. And I would recommend anyone listening to this on Spotify or an Apple platform, go to our YouTube site, The 27th Degree with Chris and Nancy, and look at this video that Dr. Marcovici is going to walk us through right now. It's just a general video of the actual robot.
Yeah, so I use a robot that's called Excelsius, and they were really the first to market. And I do think there's an advantage to going to the YouTube and watching it, because I'm sure everybody wants to know, what does this look like? And there's a workstation where we do our planning, and then there's also the cute little eyes that monitor the patient. So the patient gets a CAT scan, as I mentioned, and then we look at that CAT scan as surgeons, and we decide what size screws and what sort of construct we want to create. We decide that, and we plan that all before surgery. And then we have to put these markers in place that basically tell the computer and the robot where the patient is, because otherwise the patient wouldn't know. We do intraoperative x-rays, and then the computer correlates that x-ray and those markers with the CAT scan. So now it can bring the two together. Then you confirm your plan, and you do that on the workstation, and then you bring the robot in. And the robot has this arm, and the arm says, okay, you told me you wanted to place a certain size screw in a certain place, and then step by step, it will take you there. So we activate the robot, and it says, okay, let's say you want to put this into lumbar 5 or lumbar 4. This is where you need to go. And so we make a little hole, and that can be just very tiny, the same size as the screw, and then we put that screw in place. We do have freedom to adjust it, but for the most part, the robot just takes us to each of our screws. And here you can see the screw placement through tiny incisions, which really minimizes pain and blood loss. Patients often can go home the same day or sometimes stay overnight. And then if you want to do anything besides placing the screws, like if you want to shave some of the bone off or remove the disc, the robot will take us exactly to the disc with a minimally invasive retractor. So we'll go right there to the back part of the bone, or what we call the lamina, and you remove that, and you can remove the disc. And there's no need to cut more than is absolutely necessary, because the retractor is very small and is perfectly placed. So you don't have to say, well, I need to cut a little bit more in case I'm off. Here, it's 100%. You do what we call the intradiscal work, and then it's done. And one thing it's done is made the blood loss much less, made the pain much less, but it's also much, much faster, because it's eliminated the guesswork.
Suppose the plan changes, like when you get in there. Suppose like you get surprised and see something like you're like, oh, now I have to kind of do maybe something additional or do something a little bit different.
And the robot is very capable of doing that. You just have to do an x-ray, and you can readjust your plan on the fly, and there are actually protocols built in for that. And then you just continue with your new plan.
So you can use it for spine surgery, cervical surgery, neck surgery, and brain surgery too, I assume?
And brain surgery too. You just basically take the MRI or the CAT scan. Through the same process, you tell the computer where you want to go inside the brain, usually towards the tumor. And and then again, similarly, you have to tell the computer where the patient is, and then it will take you directly there. So There's no more what we call exploratory surgery, get in there and see what you have. You make the cut in the skin the same size that you need, no larger. You make the hole in the skull no larger than the area necessary for the surgery. And it takes you exactly to the tumor. You don't have to go left, right.
That's great. I know there are people out there watching this who are saying, gee, I was at work today, my laptop crashed 8 times. I'm
The
assuming,
Wi-Fi shut off.
yeah, but this is obviously a much more advanced technology. So,
It's very robust.
yeah.
And in the end, I think you have to echo the words that Jerry said, that, in the end, we're doing the surgery, but things can happen. You can have software problems. Sometimes you can't correlate the images, and you still have to be able to prepare to do it
the old-fashioned way, I guess.
in fashion way, whatever tools you have.
Yeah, interesting. It's fascinating. Now, your robot is, these 3 robots are all different. It sounds like, because they have different functions.
Correct.
So, yeah.
Correct.
And they must look different, too, and
Very
function different.
Very different.
Fascinating. Yeah.
I think Jim's robot is probably the largest of the 3.
It's the scariest. It has 4 arms to it.
Yeah, you're right.
And has 4 arms.
What's the name of your robot?
It's the Da Vinci. And there's
Oh, you don't have like a special name for it?
no. And there's actually several models. There's an X, there's an XI, there's now a Generation 5, and there's a single port Da Vinci robot, depending on what application you're using.
Dr. Katz, what's the name of your robot?
It's called the Makoplasty robot.
Oh.
But, when the patients get wheeled in the room, they say, where's the robot? And I point it out and say, you can name the robot today. So it's got a different name every day. It's a Makoplasty
I
robot.
would name it Giselda. What would you name it?
I'd have to think about that. Not sure. You caught me on that one, Nancy.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
So is there any surgery you can't do with the robot? What are those surgeries? All of it?
Yeah, I'm going to turn the question around. There are surgeries that you can do well with a robot, that the robot's designed for.
Okay.
And there are other surgeries that aren't designed for a robot. I mean, or yet they're not designed for a robot. For instance, in orthopedics, there would be a utility to be able to do ankle surgery, total ankle replacements, the same way you would do a knee replacement, because you can make, the same type of decision making would go into it. But the robot's not there yet in terms of the companies haven't really developed that yet. Okay. So other surgeries are still done the old-fashioned way, but I think robotics is going to catch up in a lot of ways.
Nice. So the robots you guys were using 5 or 10 years ago, what's different with today's robot, and then what's coming in the future? What do they improve on in the robots? Is it graphics? Is it?
So our robot, you can overlay MRIs and CT scans, so you can look at tumors within the liver, within the kidney for those surgeons. So just like Dr. Marcovici was saying, that you can pinpoint exactly, not to guesswork, for smaller tumors, exactly where you're going to cut. And just better fine movements, high magnification.
Yeah.
Different instruments so basically they always get feedback from surgeons. What do you need it to do? And if it's something that they back reverse engineer to give you what you asked for. And then a couple years later, it comes out.
Is that what you find to be true?
In my robot, it's basically the software has improved. I started doing this in 2011, and the only application initially was for partial knee replacements. Then it became total knee replacements and partial knee replacements. Then it became hip replacements and those knee replacements. So the software improves, and then the application of it improves as they find other uses for it.
Does the design of the robot ever get upgraded too, or is it just software updates?
Well, for my robot, mostly it's software updates. There's internal hardware improvements, but outwardly, if you looked at the robot, you wouldn't see a difference.
And how come your robot needs 4 arms? It's excessive.
Our robot has looked sleeker over the years.
Okay.
When it first came out in the 90s, it looked like a lot different than it does today. And the reason you need 4 arms depends on the complexity of the surgery.
Oh. But it's still just you doing it. You're just choosing what arm you want to.
Right. And the other thing that the new robot does is a couple of generations back, the robot just stayed there and just the arms moved. Now the whole robot spins.
Oh.
So you have less collisions, and you can actually bring the robot anywhere at the patient at the bedside and just put it where it needs to be, versus the other one you had to say, oh, I'm doing this case, I got to put it here, I got to put it here, I got to put it over the head of the bed. So if you're doing a bariatric surgery or a hiatal hernia repair,
Yeah.
you have to literally go straight over the head of the patient. No longer. Now you can go on the side of the bed and it just spins to where you want it to go.
Are there less people in the operating room now with the robots? I mean, do you need as many assistants? You still do?
You actually need more. Now you need someone to run the robot and help you with the robot as you're doing it. So the technology helps in many ways, but it also adds complexity to it as well. I think the neurosurgical robot is probably, since it's the newest, has the most room for advancement.
Yeah.
And as Dr. Katz said, there are a lot of software updates, but I'm very hopeful to see a significant marriage between the robots and AI. I think predictive treatment, and again, it's going to be your surgeon who makes the decisions, but having AI help you. So I'll give you another example. Everybody's from a totally different field, but in the field of radiology, there was always a debate of whether AI or a radiologist can detect breast cancer better.
Yeah.
And the truth is, the highest detection the highest detection rate and the smallest number of false positives comes when they both look at the same picture. So the marriage of surgery and AI, I think, is going to be very exciting. What's right around the bend for neurosurgery is marrying the robot with intraoperative CAT scan.
Okay.
So right now we take a CAT scan that was done before the surgery and marry that with images, and that's what the robot is basing on. But if you could do a CAT scan in the operating room and then use that information, you could literally have real-time adjustments. So you said, well, does the plan ever change? The plan sometimes does, but you have to remember that while the patient is in the CAT scan machine, they're slightly different position, than when they're in the hospital during the operation. So for instance, in my case, when they have a CAT scan, they're lying on their back in the CAT scan machine. And when they're having surgery, they are face down, right?
Oh, okay.
And so one of the things that actually both Dr. Katz and I treat is deformity, spinal deformity. So could you imagine a case where you're not just working on a spine that's curved, which is the state it was in when the patient had their CAT scan, but actually in real time seeing your level of adjustment. So you could actually on the fly repeat the CAT scan. So that's extremely exciting. Then there are other applications which are a little bit further down the line, combining spine surgery with Dr. Hermenegildo's specialty. Spine surgery is most often done through the back, but there's actually a lot of spine surgery that we do through the front of the body, through the abdomen. I can't wait to see a marriage of our two robots where the entire spine surgery is done through the front, through a tiny little port instead of a large cut. That's certainly something that would be extremely beneficial, but is nowhere near ready.
Does the size of the patient impact robotic surgery? Does it make it easier to operate maybe on a larger patient, or is it does that come into play at all?
I would say, and I'd have to ask my colleagues their experience, but actually operating on a larger patient is easier with the robot than doing it, quote unquote, freehand.
Yeah.
Because the robot takes you to where you want to be. Whereas if you're using just your hands and your eyes, and you're working through a deeper incision, it can prove to be more challenging.
Okay. So I want to also expand a little bit on the future of robotics. You've already answered some of the questions. I'm not sure if you want to add more about what you think the future will bring, but I want to ask Dr. Katz and Dr. Hermenegildo too. Is there anything else you think in neurosurgery that you see on the forefront with the use of the robot?
I think right now, the only thing I could add is the cranial application.
Cranial.
Operating on the brain. So right now, it's usually mostly used for guidance, but I would love to see it being helpful in resection because just like Dr. Hermenegildo said, there are robotic possibilities where the robot can achieve angles that the human being can't. And similarly, robotics gives you just such a much higher level of precision.
So there are places you might be able to get into that you wouldn't be able to normally. That's actually a fascinating aspect.
Absolutely.
How about Dr. Katz? What do you think the future for robotics and orthopedics is?
I kind of touched on it before. I think that as the software develops, more and more parts of the body will become the purview of robotic surgery. I mentioned something about ankles,
Yeah.
maybe elbows, shoulders. They're beginning to do that now as well, as far as positioning the glenoid, what the glenoid anatomy is, and what kind of provisions you have to take in terms of putting in shoulder replacements as well.
Okay. Jim, what do you think?
There are several robotic companies that will be coming out with their robot in the next several years. So going down the road, it might not take much time, 10, 15 years. There probably will be no laparoscopic surgery. It's either going to be robotic or an open procedure. And the more and the better that the robotic platforms get, the less open procedures there will be.
Right. I mean, and the recovery, you touched on this before, but if someone has a major abdominal incision, so lots of potential complications and whatnot, of course, but the recovery, what is the recovery for open laparotomy versus, where they've opened up the entire abdomen versus a robotic procedure?
We've had, let's talk about a colon, for example. So you can do a sigmoid colon resection. They can be home post-op day 1.
Okay.
And they can be back to work depending on their job within the week.
Ooh.
If you do a full laparotomy, they're in the hospital with pain for about 5-6 days. They can't lift more than 20, 30 pounds for 4 weeks.
Right.
And then you have seromas, hernias, and all the other complications, possible infection. And then never mind the adhesions inside that 2 years from now, you're going to be in the hospital with a bowel obstruction. So it literally is night and day. So if we can find a way to do less open surgery, but enough to maintain your skills,
Right.
you can't.
That's a good point.
So that's another question I was going to ask you. And I was just thinking when I was kind of preparing these questions, I'm like, there's a lot of medical teams that go to like third world countries. So like you have to maintain like some level of skill because I don't think they have your robots and...
The Da Vinci robot has the capability to operate at different locations.
Yes, son.
Yes.
How does that happen?
Just need an internet connection.
Just need a stable internet connection. But
you need the machine though.
And the machine.
So they have the robot there. You can be somewhere else, but you just have to have a capable surgeon there so that if something happens or you need to open, they now can do the operation.
Wow.
Still have to have someone put the ports in the trocars, and then someone just passes the instruments in, and your speakers to their speaker so they can hear you no matter where you are.
Wow.
That's the future. So in places that they won't, if they have a shortage of capable surgeons, they can get their minimally invasive surgery done.
And this has been done.
Oh, no, it's been done.
Yeah. Yeah.
It's just that's not on a grand scale.
Some interestingly, I think you have some pretty tremendous like military applications for,
Yes.
wartime if we had robots there.
Came in like a command center room with a bunch of surgeons. And
Well, I mean,
like,
you might not have a general surgeon. Well, you'd have to have a surgeon there, but the robot would be
You might not have the minimally invasive surgeon there, but you have the general surgeon there.
right. I get it. Yep, exactly.
that just kind of blew my mind. So, and I don't know if you know the answer to this question, but are robotic the robots different regionally, like depending on the number of cases or what you see, or is like, does California kind of have the same robots that we do over here? And
It's the same company.
Yeah.
it's just a national company.
Yeah. Or
You're multinational.
no, international.
So it's surgical.
So the same robot is everywhere.
So basically, with your skill set, you could kind of just go anywhere in the nation or internationally with.
Technically,
Well, as long as they're using the robot that I'm using, there's a Rosa robot that's made by another company, and a Makoplasty is made by Stryker, and so they do the same things, but they're different. So you'd have to be trained on each one.
So yours is intuitive surgical.
yes. But
Stryker. And who makes yours?
Globus, and it's the only spine robot on the market right now. But within the next year or so, there's going to be another one. It's very interesting. The Makoplasty robot is going to come with a spine option.
Really?
Yeah. So I mean, the companies realize that this is a huge market.
Sure.
And the possibilities are, so there's going to be some. Right now, there's a lot of monopolies, but I think
it is a race right now. It's a race. They know the future. They know it's going to be all robotic platforms, and every company is trying to get a robot.
So many regulations that they have.
And that's why it takes a longer time.
Yeah.
And the way these work is that you have to recreate the wheel every time. You can't just say, oh, they did it, so let me just take it from there.
Exactly.
You have to show from the beginning that yours is safe and as good as theirs.
There's also large expense to these robots that nobody's talked about yet. So I think that's probably more. When you talk about bringing in a robot to a third world country,
Right.
I mean, the robot that I used to make a robot, it's a $1 million expense to buy the robot. And then there are the disposables that you use for each case. And generally there's a service contract. So if something breaks, it gets fixed, And so these things are not inexpensive.
Exactly.
But I think they pay for themselves if you can prove that there are less complications and better outcomes.
Yeah. Do they use robotics in cardiac surgery?
I'm not aware.
not that I'm aware.
No, not that I'm aware of.
If they can, they will.
It may get there, right? It probably will get there.
All right, yes.
GYN uses it on them.
Every
Urology too, right?
Yes. Thoracic, urology, hepatobiliary. They'll do liver resections, pancreatic resections, gastric resections, all through the robot, all through little incisions. Prostates are pretty much 99% robotic.
Really?
They were pretty much the first.
So right now, in areas of the country that are poor, they're not having really the advantage of robotics.
They may not have access to it.
But
Possible.
the ones that are coming out, they're going to come out, and how they can. Da Vinci's been out so long,
Yeah.
and these new robotic companies that come out, they're going to have to compete with price.
All right.
So if someone, and our robots, like Dr. Katz was saying, they'll go from like $1 million to $4 million, depending on which model. But if these other robotic companies come out and they'll say, we have one for $700,000, now it'll provide access to other places where you don't have robotic surgery.
Right.
And that's how that's probably going to work.
So it'll probably come down in price as there's more competition.
Remember, it's a monopoly right now
Yeah.
with Da Vinci. So as soon as these 2, 3, 4 other ones come out, everything will
And stabilize the pricing.
Interesting.
When you first started using the robotics, or even now, what kind of comments do you get from the patients? Like, I imagine, the patients must come back to you when you see them, follow up, and they're like, wow. Especially if it's, a repeat surgery. Like, I'm thinking if they had a knee done, 15 years ago, now they just had their other knee done, it's probably a totally different experience.
Well, first, I think there's an education process. They have to understand that the surgeon's doing the operation and the robot's a tool to make you do it better. Yeah. I mean, when you talk to them, they're under the impression you're going out and having a cup of coffee reading the New York Times or doing the New York Times crossword puzzle while the robot's doing the operation, and that's just not the case.
Right.
So
I got to stop telling my patients.
so when you explain it to them and that it's a tool, they really understand it a lot better.
But they still, when they go to the OR, they still think it's really cool looking. They'll think, oh, there's a robot.
So, this is a bad scenario, But if you have a patient that's crashing in the OR, that robot can just be kind of slung in the corner while you're taking care of the patient.
Yes. Okay. And like you were saying, what surgeries can you and can't do with the robot? So obviously, if there's a trauma, someone's unstable, you don't pull out the robot.
Exactly.
Right.
Now you got to be an open surgeon. That's why you gotta know how to do pretty much everything. And when we go to the OR, it's all judgment and flexibility. There's a plan A, B, C, D. Because when you go in there, you can be surprised. It's not what you thought it was. It can change, and you'll be able to change with it.
Okay.
And the robot's just another tool that makes you a better surgeon and has a lot more benefits than laparoscopic surgery for patients. It's definitely open surgery.
That's the way to look at it. It's a tool, really.
It's a tool.
Yeah, it's a tool, but a very, very impressive tool.
Yeah.
For the most part, patients are very excited. You do have a few patients who will say, "Oh my God, are you going to do the surgery or is it the robot?"
Yeah.
But the vast majority are very happy that you'll be leveraging technology to help their outcome. And I'll be honest with you, I did a robotic surgery on Friday, and sometimes patients can go home. This patient stayed overnight, and the first thing he said the next morning is, I really expected to have more pain. And he was delighted and went home the next day. So it really is a benefit. And I remember doing these cases open, and it was not unusual to have to give someone a transfusion or two. And using the minimally invasive, I can't remember the last time I needed to give someone a transfusion. Even if you're doing a bigger surgery, can't remember the last time I had to give someone a transfusion when using the robot.
Can you talk a little bit about the learning curve? Not only, the first time you're using a robot, is it vastly different? Does it feel a lot different from just doing like a hands-on surgery, I think is the term you used? And then when they have these upgrades, and if they're like substantial upgrades, what's your education like when that happens?
I can only speak for myself, but there's a significant learning curve. The first 1 or 2 or 5 you do take a long time.
Yeah.
There's so many steps. And for me, what took me I didn't trust the robot.
Yeah.
So I double checked.
Yeah.
Old school. And I kept on double checking and double checking and double checking. And then once you do 10, 20, 30, and you realize you can go ahead and trust the robot, then it's going to do what it says it does. You have a lot more confidence. And to me, what's really amazing is when the patient comes back to the office, seeing those follow-up x-rays, and they're perfect every time, like out of a textbook. They're perfectly aligned, exactly where I wanted them to be every time. And then you have this enormous confidence, and you go much faster. And so something that the first time took you 6 hours is now an hour or 2.
That's fantastic. And then the patient's not under general anesthesia for that long time, too, which is a great benefit.
That's actually a good question. Does it cut down the operating time right now?
For me, it does.
For you, it does?
For me, it's about the same. There's there's a registration process that I talked about where you have to touch different areas to let the robot know where the joint is in space. That takes a little bit of, maybe it adds 5 minutes to the case. But on the other side of it, in terms of accuracy, not having to think and do things again or do things over,
right?
It saves you time on the other end.
What do you think, Jim?
It saves time. It saves time. Just think about it. With the wristed instruments, you're not fighting to get to the spot.
Right.
If there's adhesions in your way, you can get to them quickly and get to your to the gallbladder. Depending on the patient, you can get there quicker. So the operations are quicker. Okay. And just to go back, the first lap choles, just about learning curve, people are taking 4-6 hours to do a lap chole when they first started too. So whenever it goes from significant difference from open to laparoscopic, then from the learning curve from open to laparoscopic was a lot worse than from laparoscopic to robotic. That was a big learning curve.
How long does it take to do a laparoscopic cholecystectomy, take out the gallbladder with a robot these days?
Under 30 minutes.
Wow, that's remarkable.
If there's not a lot of inflammation, under 30 minutes.
That's great. That's amazing. And you have all those safeguards protecting the biliary tract and all that, which is fabulous.
And that's important because whenever there's an injury to the common bile duct, the surgeon will always say something like, "That was the easiest gallbladder I ever did." So that dye that I use goes preoperatively into the patient on every case, even if it's a young person, even if they've only had one gallbladder attack, because the anatomy could be different.
I'm gonna Google that tonight. I'm gonna Google what you see when you're doing. I wonder if that's
You can see all the videos of every operation on YouTube.
Yeah.
Every robotic case you want.
Yeah, there'll be challenges
cool.
for surgeons in training in the future. Nancy alluded to this. If everything's being done robotically, how would you learn all of those skills to do the open procedures down the road?
They do struggle now. If you go to these programs and you're doing majority of the laparoscopic robotic cases, they are not as strong on the open operations as they were in the past. Yeah. And that's just something that we're dealing with.
That's interesting. Yeah, because you have to know what to do if you can't use the robot if someone crashes or whatever the issue may be. So that's...
Well, to reassure the audience, we're sort of in the golden age because you have surgeons who trained on open and now have learned robotics. Before the robot wasn't available in the future, people will only be familiar with the robot.
We'll have to come back in 20 years and have this discussion again, right?
I would think ER trauma surgeons probably won't.
Well, that's not going to affect them.
And Jim said if there's trauma, it's probably going to be open.
Yeah, so they'll always have some surgeons in the future that will know.
I think training programs, it's incumbent upon them to produce surgeons, not technicians.
Yes.
Right?
That's great.
And so I think that training programs, at least in orthopedics and probably in neurosurgery and general surgery, are still going to teach the basics of how to be a good surgeon.
Okay.
Yeah.
And then you will use this as a tool.
They may not have as much open case they use it, but they still have it because there's a lot of complicated abdomens out there. So they'll see it. It's just not as much as we saw 20 years ago, 25 years ago.
Well, this has been fascinating.
I know. I love having a panel too. Oh my God, this was great because we had 3 different perspectives. Yeah. Thank you, gentlemen.
So as we draw to a close, is there any one message you'd all like to leave the audience?
It's just that robotic surgery is the path forward. It's the best for the patient. It's ergonomically the best for the surgeon. All the metrics are in its favor.
I'm just going to spend a second and talk about change.
Okay.
Change isn't always bad and change isn't always good. In terms of robotics, I think in general change is very good. And just not to be afraid of change. That just because the surgery that you might have may be different than something your parent had or an elderly relative doesn't mean that your surgery is worse. It's probably a lot better because we have tools now that make the surgery better.
Thanks. Thank you.
As a surgeon, I just am thrilled that I'm able to practice through such an exciting time, that tools that I could have never imagined when I came out of training are now available. And I was trained in a time where, you became a good surgeon if you knew how to eyeball a screw. And now you have a robot that gives you so much more precision and safety. And that's really what the most important thing is. And I'm just so excited, and I hope my career lasts long enough to see, as I mentioned, the marriage of AI and different technology and different techniques to see what the next evolution and robotic 2.0 looks like.
Exciting. Well, thank you so much. It's been a great discussion. You guys are a great panel. Wonderful having. We've never done it with 3 docs before.
I love
this great
because you just get such a nice perspective all around,
and a little bit little differences, which is nice to hear. I'm sure the audience really appreciate it. So I do want to thank everyone for listening to our show, and if you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. Primacare, your trusted medical providers in southeastern New England, and the Bioskills of Northeast for producing our show. They do a great job. They're available to produce your show, and if you are interested, call 774-301-8811. Bay Coast Bank, our sponsor, is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more about all they have to offer. and Duncan Hearing Healthcare, also sponsoring our show. Thank you very much. You can Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thank you, everyone, and we'll see you again down the road.